I'll start today with case 1, a female patient 69 years old. She complains from yellowish discoloration of the skin and sclera. She has history of ERCP done twice, the first time 3 years ago and the other one was 1 month ago in October 2019, showing multiple stones. 2 of them are large stones, more than 2 centimeters with insertion of 10 French 12 centimeter plastic stent. With failed trials of extraction of stones, patient is for lithotripsy.
Okay, we are online.
We like, okay. So, good morning everybody.
Hello.
Great pleasure to introduce Marco Giovannini, who will be working with me, and also the endoscopy team here at the High Cost Military Hospital. And we thank Professor Ibrahim Mustafa for the nice invitation. And let's go to the case now. We are treating a lady with multiple stones in the bile tract that have been already evaluated for traditional removal with Dormia, and they failed twice to remove the stones. So I want to show a couple of things before we get started. First, the patient is intubated, and she is on the left lateral decubitus. So when we do spyglass, we always intubate patients because we expect a very long procedure, and also we are going to use a lot of water. We want to prevent the risk of pneumonia aspiration. The other point is the scope. I'm using the bright new Fujifilm AD 580 XT. With the standard trapezoid dormia from Boston Scientific, the stone that has fallen down nearby the papilla. Finally, we will introduce the spyglass into the bile duct and we'll try to make electrohydraulic lithotripsy of the biggest stone which are higher up into the bile duct. So let's start with the dilation. So we are using standard pyloric balloon dilation, 12 to 15 millimeter. So if you can have X-ray for a few seconds, please. X-ray. Okay. So normally I position the balloon in between the bile duct, the duodenum. So I try to stay in the middle. We have fluoroscopic markers also that can tell us exactly where we are into the bile duct. Afterwards, I straighten the scope a little bit like this, and I start doing, I leave the elevator at this point, and I ask my nurse to start with dilation. So please go ahead with dilation.
What's are the complication of this kind of dilation?
Thanks for making this point, Mark. So normally this maneuver is considered very safe, dilate.
Yes, I know.
It's considered very safe. We need to
be careful with the risk of perforation and with the risk of pancreatitis. So it's important that you do not exceed the size of the bile duct.
Of the bile duct, yes. This is a
Because
very
when you
important.
go too much high up to 12 or 15 or 20 millimeter, you may be tempted in case of big stone, you may increase the risk of perforation. You know, you can have a look to the bile duct through the balloon. So we are now to 12 millimeters. So fluoro, please. You can see the balloon is already expanded to 12. I turn the scope a little bit and try to, okay, stay just in front of the balloon. Now go to 13 millimeter, please, slowly, so you can take your time. You don't need to hurry up or to rush. There is no pressure at this point. You can start seeing the internal part of the distal bile duct. The whitish epithelium is just the bile duct, yeah. And we are to 13. And now go slowly to 15 millimeter.
And the same question, how long you stay with the balloon
There are
inflated?
studies showing that at least you should stay, there are randomized trials showing that at least you should stay 30 seconds. I think that this is very variable. It may depend on the specific situation. If you are in the nice position with your scope, you have your time, you feel comfortable, you can stay up to 60 seconds waiting for the remodeling of the papilla shape using the balloon. So we are 15 now? Yeah, go to 15.
Dr.
Okay,
Alexandro,
we are increasing now.
we have a question here. We see
Sure.
medium-sized diverticule
Yeah.
close to the papilla.
So that's another very good point. The presence of the verticulum itself is not a contraindication to the balloon dilation. We are in a little bit different situation here because the verticulum is not into the area of the papilla, but it's on the lateral side. So probably specifically for this case, it doesn't have too much impact on what we're doing. In the case of the papilla in the middle of the verticulum, I do suggest to be a little bit more careful. Don't do full-size sphincterotomy. You do short sphincterotomy, small-size sphincterotomy, and you do not go up to 15 millimeter. You can probably limit to 12 or 13 millimeter, but actually this is a very good point. So I think we went to 15 now. Can we have an X-ray? I cannot see any indentation at the papillary level, so we wait about 20 to 30 seconds at 15, and afterwards we deflate the balloon, we leave the guide wire into the bile duct, and we try to extract the
10 minutes, okay.
down stone with the trapezoid dormia. Okay, just deflate.
In case
So,
of bleeding, how you're going to manage this?
Very good point. Depends on the kind of bleeding. You have several options, including injecting adrenaline, but sometimes when you have a significant bleeding, you may need fully cover the metal stent to manage the bleeding. So,
Mainly the bleeding stop.
yeah, normally the bleeding is self-limiting, even though it looks quite significant here, but it's just very early. And once you start sucking, you can, okay.
So the amount of
We
bleeding,
are removing.
how you could judge the amount of bleeding, whether it's could be treated conservatively or you have to do more interventions?
It depends. Normally, I don't evaluate the bleeding right now. I will wait until we are done with the procedure. At that point, I will advance the guide wire, please. Advance. Okay. Once we have completed the stone removal, we will consider what to do with the bleeding.
But if you succeed to remove the stone, all the stone, you are sure that you need
Okay. a stent.
The lithotripsy with the spyglass after such dilation.
That's a good point. Let me see what's happening with the first stone.
Yeah.
Okay. Give me trapezoid, please.
Now
And
you
okay.
see the bleeding stop now. It's
Yeah,
sometimes
it
the
takes
bleeding
a
seems
little
more
duration.
important because you as the bile is pacing on the on the blood and this and
Okay. Now you can put some contrast medium also. Okay. The issue with trapezoid is a little bit rigid when it's at the first pass, so you need to go from
but now
this
you have
position, okay?
you have a
Fluoro,
large
please.
sphincterotomy.
Fluoro, okay. I don't want to go very up. I pull back, fluoro, fluoro. And now you can open now. No, sorry. Hold on a second.
You're out. Yeah.
Okay, I'm out. Just 1 second.
Okay.
Okay, do again. Okay. Now you can open now. Okay. Okay. Once the nurse is opening, I'm trying to pull back and play with the dormia in order to catch the very distal stone.
Stone and the first
Yeah.
one.
Let me do again a couple of times.
So you are
Okay,
trying
fully
to catch with the dormia pusket the stone in the CBD.
The very distal stone.
Okay.
I don't think I have anything here. So close.
Maybe you should
We do
inject
cholangiography, yeah.
some contrast
Yeah.
just to see because sometimes with the balloon that you push the
We
stone.
probably push the stone a little bit
Yeah,
high
yeah.
up. Okay, let me get position again. So you see now
Now there is
it's
some
Professor, we have a question here from the chairperson. What about the size of the stone and its correlation to the diameter of the papilla?
okay. See, okay.
inject some
So
contrast.
the correlation is that normally we do not go up to 15 to 18 millimeter. So
Inject
open,
contrast.
open a little bit,
Contrast,
open a
contrast.
little bit, and inject contrast. Okay, stop. Okay, now inject contrast. Okay, contrast.
Inject water. Huh?
Okay, inject.
What happened?
Okay, keep injecting.
There is a rupture of the duct.
Can I have fluoro, please?
There is,
Okay.
okay.
You see the bile duct there? Okay, there are multiple stones. And now I try to fully open. So probably the dormia is compressed by the stone in the middle part of the bile duct. Okay, now let me do this maneuver. I advance the duodenoscope, trying to straighten the bile duct like this. Okay, you see? I'm advancing a little bit more and advance the dormia and trying to play with the dormia, but my feeling is that we go with the dormia on the lateral side of the stone. So let's do this again. Okay. Oh, there is nothing. So let's go with the spyglass. Okay, you see, we still have a little bit of bleeding, significant amount of bleeding here. If this bleeding is continuing, we may consider to use a metal stent and advance the spyglass afterwards. So can I have the spyglass? Yeah.
Will be, you don't prefer to inject some adrenaline first to stop the bleeding?
I don't know exactly where the bleeding is coming from. You think it's here?
Yeah, I think.
Yeah, okay. I think this is a good point. So Mark thinks that the bleeding is coming just from the apex of the sphincterotomy. So can we have some adrenaline and an injector first?
And with the Carlock needle, the Carlock.
So they do not have the Carlock already.
You don't have the Carlock needle?
You have the Carlock?
Injector.
Yeah.
Carlock injector.
So what's the concentration of the adrenaline you would like to inject in this case,
So
and
it's
how much?
1 in 1,000 standard concentration.
Okay, and how much is the amount? How many cc's? Your maximum, or it's?
So it depends. At least we will inject a couple of cc. Let's see what's happening here.
Okay. Would this interfere or make a little bit challenging introduction of the spyglass later on, or doesn't matter?
Sure. Even though we can use a flashing for the spyglass, I can predict that the blood is making our procedure much more complicated. So this is Boston. So you need to cut a little bit of the needle to use with the duodenoscope. So pull back. Use a scissor and cut here. Yeah. So we do not have the Carlock needle, we are using a standard Boston needle. When you use a standard Boston needle, you need to
show
cut
the injection of
about
adrenaline
1
and after
centimeter,
you
so now
change.
there are some bile in between
As you
the
want. Okay.
blood. So you need to cut at least 1 centimeter of the external plastic sheet, it's good.
We heard that you have done sphincterotomy before you start dilatation, Professor?
No, the sphincterotomy has been done 3 years ago. At the time of the first cholangitis, the patient was treated just with sphincterotomy plus stent placement, so needle out.
So we could leave you to do your injection, and we will come back to you after shifting to
Okay.
another examination. Okay, good luck.
Okay, needle is out. So you can see we injected some saline at the level of papilla, so bleeding almost stopped. I can show you in a few seconds. Okay, we do not have that torrential bleeding that we saw before. And we introduced the spyglass, and we are trying to understand what is the situation inside the bile duct, because we couldn't get a very good cholangiogram. So we still, okay, you see this is the big stone probably. We are at the side of big stone here. You can recognize the stone. So probably now we can start the lithotripsy at this level. So we now remove the guide wire and we introduce the electrohydraulic lithotripter fiber. The problem I have this time, okay, now I can see a little bit better, that there are multiple stents, okay, you see here, and probably we need to start from this one. So it will take a significant amount of time. Okay, once we're ready, we introduce. Okay, we're ready with the lithotripsy.
You have removed the guide wire.
Yeah,
And
so
to
we remove the
replace-
guide wire. So one of the points is, if you look to the fluoro
Next way,
picture,
please.
the problem is the scope position. So I'm in a very tight angle. It's difficult for me to keep the position of the duodenoscope, or the mother scope. And I don't want to risk to lose the position all the time. So I'm aspirating all the fluids, and now trying to steer the, okay. That's my first target. Okay, you see?
See, I could see as well there is like papillary form reaction mucosa around the stones in the CBD.
No, also probably because of the stent. The patients had the stent for more than 2 years.
And this could end up with segmental inflammation,
Yeah.
stenosis.
Exactly. So you ready? Okay. So let's the fiber going out. No, you should remove the protection from the plastic. The fiber has to go alone without fiber.
Here there is very nice photo
no,
for the
you-
mucosa. I see this
Yeah,
inflammatory process clearly covered with fibrin distal to the stone.
So let's solve one problem very quickly. You see this doesn't go through. Yeah. So we need to get the fiber out, which doesn't go through. No. Okay, let me give you different angle.
There is the angulation that
Yeah,
is
it's
very
probably-
tight. Yes, the position is.
Yeah,
Sometimes
I'm releasing the elevator, trying to reduce.
Sometimes you need to push in
Yeah.
the
Okay.
the
It's
spine
out.
and the fiber of the
All
the
together.
forceps in the same time.
Yeah, okay, now we are a little bit better now. So can you push or not yet?
You should push in the same time.
Professor Bici, I
X-ray.
think during
So probably we should.
during cholangioscopy,
I'm
it is
pulling back.
it is important to
You
keep
see
the
the
duodenoscope in position. How can you keep your duodenoscope position in order to do that cholangioscopy comfortably?
Can you repeat the question? I cannot hear you.
How can you keep your duodenoscope position in order to do the cholangioscope comfortably?
That's a very good technical point. It depends on the anatomy of the duodenum. This anatomy is very cumbersome, you see. And if you look the fluoro, so I'm pulling back, try to see, it's coming out. Let me pull back.
You are out.
Okay. So let's try to advance the. Doesn't go through. So we have an issue with advancing. So I do propose you move to another room. We try to solve this issue and come back here and we show how to make the lithotripsy once we have the fiber inside. Okay? Okay. I remove the spyglass from the working channel, but despite this, you see, it's not a problem of angle, so it doesn't go through.
It's a problem of.
Yeah.
So I have some technical point for the spyglass as a technique.
Yeah, in the meantime,
Yeah.
you're working on the spyglass. I try to use the trapezoid to remove,
The small fragment.
yeah, the small fragment over there. Can I have trapezoid?
Yeah.
Ah.
The-
Okay.
Okay.
So they are changing the spyglass because there was problem.
Okay,
technical
we will shift to
problem.
You,
the first.
you prefer to use
to
the Dormia basket than a balloon in this case?
Yeah, very good question. So I think they are equivalent. Since now we don't have any guide wire inside, we can try with Dormia. And also the other point is the bile duct is very dilated, very dilated. So we need a super big balloon.
Yes.
So let's go. Can we have fluoro? Okay. Now open the dormia. Open, open.
We need the fluoroscopic picture.
Now we can finally have a better view without blood.
Screen.
Okay, let me make this. These are probably the fragments that were down. Close the dormia. Okay, fluoro please. Open. You see, the dormia make a very tight angle, which is probably on the side of the big stone
Yeah.
there. And when I pull back fluoro, so I cannot catch any big stone in the area.
We change for a balloon extraction.
So we looked into the spyglass system. We had a problem with the spyglass. So the spyglass catheter was broken. We are replacing with a new one, and we are using now guide wire plus balloon to extract some fragments. Okay, we ready? So inject. Okay, now, oh, it's very big, you see? Now, okay, you see there is a small
small
stone
and-
there.
and
So we have to remove first the small stone. So advance the guide wire up into the bile duct. Okay. Pull back the guide wire and advance. Okay, now advance. Advance. Okay, advance. Good, good, good. Keep advancing. Okay, like this. Okay. Now I pull back a little bit and you start inflating here. And see if we can remove the small stone. So it's, no, it's nothing. So deflate. Okay. Fluoro. Okay. Can you inflate, please, now? Inflate. It's fully inflated. Okay. Now pull back, pull back. Have a look. Fluoro. So we completed the extraction of the fragments of the big stone,
Okay.
and we understood what was the problem. Indeed, it wasn't a simple bile duct stone. There was a Merizzi syndrome. And we were working in the space of the cystic duct. So now we were able to place, so we removed all the fragments, you can see here, and we were able to place a guide wire into the common bile duct. Can you have fluoro, please, now? Okay, now finally we are in the common bile duct. So I'm going, and advancing the balloon there, and inflating the balloon, and now we make a cholangiogram and try to understand what is the situation in the bile duct. Okay, inflate, full inflate, okay, and now inject. So the problem was we didn't look to the MRI because it wasn't available, but this was a case of a Merizzi syndrome. So the stone that we removed was in between to the bile duct and the cystic duct. And you see now we are pulling back. Once we have removed all the big stone, we are pulling back the other fragments that are coming out in a different way, much easier now. Okay, you see? Deflate. So there was the problem. We got stuck for certain time because we had no MRI. We could not recognize that the stone was in between bile duct and cystic duct. And also, I think that the stent was originally placed into the cystic duct. And this is why the patient was having cholangitis very frequently.